Welcome everyone. Thank you for joining us in today's webinar. My name is Dr. Pritesh Patel and I am the Medical and Scientific Manager at Nestle Health Science. Today we will be discussing managing gastrointestinal intolerance in critical ill patients. For the discussion, we have an eminent speaker, Ms. Daphne DK. She is the Chief Clinical Dietitian and Head of the Department of Dietetics at Apollo Hospital, Chennai, with over 23 years of expertise. She is also the director of Apollo Clinical Nutrition and Dietetics Internship Program and member of board for studies at Universities of Madras. She is also the member of European Society of Parental and Enteral Nutrition, American Society of Parental and Enteral Nutrition in 2020. She is the reviewer of various key journals like Journal of Parental and Enteral Nutrition and Journal of Human Nutrition and Dietetics. She has multiple national as well as international publications in her credit. Welcome, Ms. Daphne. Now, before we start the session, I would like to inform everyone that there will be an interactive polling sessions in between the presentation. Please check the polls icon on the right side of your window screen to select the answers. We will be informing you whenever there will be a polling question uh, asked. So now, without further ado, I will request you to enlighten us on the managing GI intolerance on critical ill patients. Over to you, ma'am.
Thank you, Dr. Pratish. It is indeed my pleasure to join and share some thoughts about managing GI intolerance in critically ill. I think few weeks back we had a session on stress-induced hypoglycemia in critically ill. So you see the importance given to critically ill, especially during this pandemic. You see a lot of critically ill patients in this setting. So that is one of the main reason why we have chosen this topic. And as dietitians, we have to be enlightened in managing GI intolerance, especially in critically ill setting. So my talk points would be prevalence and mechanism and consequences of GI intolerance and GI intolerance in critically ill. What is it? How do I define it? Why talk about it? What are the causes? What is causing GI intolerance? And how? How do I handle as a dietitian? So that is what we will be seeing. Apart from that, dispelling some EN practice myths, which is pretty common across all practices, all of us. And finally, not to leave out our COVID pandemic scenario and COVID and GI intolerance. This is the crux of what I will be talking today. Without delay, we will start. When we talk about GI intolerance, the first thing that come into your mind is a compromised GI function. And this is pretty common in critically ill patients. And it is about 30 to 70% of ICU patients have some percentage of GI dysfunction. And for all of us, the first choice to feed a critically ill patient is enteral nutrition, right? So when your gut is functional, use it. That's what we've been taught, and that's what we practice. So why there is a dysfunction? It could be attributed to the diagnosis, the ventilation mode, premorbid condition of the patient, metabolic state in which he is in, and various medications, because it is polypharmacy. It is not one medication. Umpteen number of medications put together. We want to pull the patient out, right? So the medications can also play a role in GI dysfunction. And mind you, GI dysfunction occurs in about 50% of mechanically ventilated patients. It's as high as that. But the percentage might be different. It can vary. It can be a mild dysfunction to a very severe dysfunction. So the proposed mechanisms and in ICU and post-operative GI dysfunctions are mucosal barrier disruption and reduced mass of GALT, gut-associated lymphocyte tissue, altered motility, which is very, very common, and all of us would have encountered this, and atrophy of the mucosa. So, before I go on to taking you further, let me just run through a little bit of basics because I'm not going to spend long time in basics. So I thought I'll put a poll with regard to indications. A typical indication for enteral nutrition is select one of the following. It's intestinal obstruction, inability to gain access, enteral access. Third, neurological impairment. All of us know if a person is not able to have adequate food intake orally, then you think of enteral nutrition, right? And there are other conditions also where oral intake becomes very difficult, like head and neck cancers, upper GI cancers, then inherited metabolic diseases, just naming a few. And majority of critically ill patients and ventilated patients, most of them, because the first route of choice is enteral, right? So only when your gut is non-functional you think of parenteral. So can we have the answers, Pratish?
Yes. So what we are doing is that we are starting the poll now.
Okay.
So I request all the participants to kindly click on your right hand side, the pulse icon, and you will see the options. So you can select on any one of the options which you consider it correct, and that is going to give us the information.
So when we talk about indications, there are some contraindications also for enteral nutrition, right? Like a short gut, right? It could be a surgical resection,
Mm.
and it could be a high output fistula, or it could be ischemia of the bowel. So all these are major contraindications of enteral nutrition. So we have to be very, very cautious in understanding it as dietitians who handle critically ill patients.
So, ma'am, we have the answers. So,
Yep.
majority of the participants have selected intestinal obstruction, almost about 53%. Second to that is inability to gain enteral access, almost 27%, and neurological impairment to be the least at 18%.
Oh, but the answer is neurological impairment because they won't be, fit neurologically to take orally. So obviously, enteral nutrition is required. It could be a stroke patient or any neurological impairment. Long-term enteral nutrition is required. An intestinal obstruction, whether it is an obstruction which requires surgical correction or not, you don't know. How will you start them on enteral nutrition? And if you don't have an ability to gain a enteral access, how will you feed the patient enterally? So it is neurological impairment. Okay, moving on to understand the GI intolerance definition. Do we have any specific definition for it? We do talk about absence or abnormal bowel sound, vomiting, bowel dilatation. Diarrhea is a common thing when you go into your ICU, you hear, ma'am, the patient has diarrhea. This patient has GI bleed. This patient has high GRV. These are all common terminologies what you relate with GI intolerance. But how do I define it? The definition given by Aspen is GI intolerance is usually defined by vomiting, abdominal distension, complaints of discomfort, high NG, nasogastric output, high GRV, gastric residual volume, diarrhea, reduced passage of flatus in stool, or abnormal abdominal radiographs. So we have to be very clear that any of this is related to gastrointestinal intolerance. So how do I determine it? As a dietitian, you may not be the person to determine it, but you should understand that tolerance may be determined by physical examination, which your doctor does. And that is very important that you read through their notes thoroughly. Passage of flatus and stools, that is a sign, and radiologic evaluations. And finally, it is your patient who tells you, right? He complains, I have pain, I have distension. I'm feeling really full. I'm feeling very uncomfortable. These are things that you will hear from them. So these relate us to determine how comfortable, how tolerant they are. And one of the surveys, we found that it is not our study, it is one of the person, Metheny, had reported about 97% of the nurses. They solely thought intolerance is about measuring GRV, and if it is high, patient is intolerant. It is not that way. So you should understand it is so many factors which are involved. So one of our early papers where we looked at the interruptions in critical care. Obviously, critical care is 24/7. So why should critical care nutrition be interrupted? Was the question. So we thought we will find an answer to it. So we found, since it is a GI related section, so I'm talking only about the GI symptoms. So we found that patients had abdominal distension, diarrhea, GI bleed, RT aspiration, and melena. And we find the number of hours against the number of patients. Okay, so it's about 18 to 22%. And we had about 350 patients whom we had analyzed. And we found that GI symptoms had longer interruptions compared to any other interruptions, like the procedures inside the CCU or outside CCU, and other nominal procedures like bed care, what they give, nurses interrupting feeds. Between all this, GI symptoms weighed higher, and longer the interruption, the lower you're going to give nutrition, right? GI dysfunction coupled with inadequate nutrition. GI dysfunction significantly compromises the delivery of EN in ICU patients. That is because there is malabsorption and intolerance, which can lead to calorie and protein deficit, leading to risk of malnutrition. And we find that one of the study had quoted 74% of mechanically ventilated patients could not attain 80% of their energy targets. That's a huge number, right? So we have to be very, very cautious about it. And only when you monitor, you'll be able to understand whether it is really right. Okay. So why do we talk so much about GI consequences, GI intolerance? Because the consequences is bad. It gives a poor prognosis to the patient, right? That's because they can delay achieving the calorie and nutrient goals. It can increase the risk of malnutrition and invariably longer ICU stay and increased mortality risk also. So it is very, very important that we understand it a bit more. So can we have one more polling question? Pratish, I think you can put up the question now itself. So the ideal temperature of enteral formula at the time of administration is?
Yes, I have already put up the question.
Yep. Okay. So how many of us understand the ideal temperature? Because some places the nurses mix and give, some places we send it from the kitchen, right? You have a liquid unit where the feeds are prepared and dispensed to the ICU. So how do we maintain the temperature? It is very, very important.
Yes, ma'am. So we have the results. And this time, I think we are fortunate to have correct results. So, yeah, almost 41% of
Mm,
the participants has voted for 25 to 30 degrees,
mm,
and 54% of the participants has voted for 20 to 25 degrees, and
okay.
5 to 10 degrees, almost 3% of the
Okay.
participants.
Okay, so majority has given the right answer. It is 20 to 25 degrees Celsius. It is so important that we do not give them hot or very cold feeds. Why? Diarrhea is one of the important factor that we are going to look at. That's why I thought I will take take you through the temperature first. Okay. So diarrhea, as you all know, is one of the factors that we look at in GI intolerance. And as we discussed, it is as high as 70% of the critically ill population have some percentage of GI intolerance. And out of that, it is about 15 to 18% of enterally fed ICU patients experience diarrhea. This number is from a particular study. It can be as high as 50% also, because different studies give you different percentages. So on an average, I can say, 25 to 30% at least will have some disturbances. So let's understand the classification of diarrhea. There are four classifications: osmotic, exudative, secretory, and motor. Osmotic, it's a very common terminology, osmotic diarrhea, right? Increase in the intestinal osmotic pressure, and there is a transfer of fluids to the intestinal tract leading to diarrhea. Same way, exudative, intestinal mucosal disorders such as inflammation, and you attribute it to Crohn's disease or IBD. There is an increase in intestinal content due to the exudates, and it leads to diarrhea. And secretory, that is enhancement of intestinal secretion by enterotoxins. It could be any viral or bacterial infection which can cause. That increases the intestinal content, wherein the secretion is more, the absorption is very less. So it leads to diarrhea. Finally, the motor, which there also you see there is increased intestinal peristaltic movement. It can either increase or decrease due to a disease condition. It could be something related to a thyroid cancer. There could be an increase. Rapid passage of intestinal content leading to diarrhea. And if there is a decrease in intestinal peristalsis, it can lead to bacterial growth in the intestine, leading to decongestion of bile acids, leading to disorder of fat absorption. Finally, landing up with increased secretion of intestinal secretions, which leads to diarrhea. So when we talk about diarrhea, you need to have it in mind: two classifications, one infectious and the other non-infectious. Because it is so important, the treatment plan is led by whether the patient has an infectious diarrhea or not. So the presence or absence of infection has to be had in mind before treating. So the major causes and risk factors are listed here, because as dietitians we should be aware of the causes of diarrhea. Because as you enter the ICU, the doctor tells you, madam, this patient has diarrhea, can you change the formula, right? This is a common question that you encounter in ICUs. So you need to analyze where things are going wrong. Is it the overdose of hyperosmotic drugs like sorbitol? Because one of the side effects of sorbitol is diarrhea. Use of broad spectrum antibiotics, that has to be looked at. Then whether the patient has pseudomembranous enteritis due to Clostridium difficile. Then intestinal infection, MRSA or CMV enteritis. All these have to be looked at. Inflammatory bowel disease could be a cause, and intestinal graft versus host disease, especially in stem cell transplantations and use of anti-cancer agents. The cause is many, but normally the error comes onto our head. The risk factor is it could be fever, it can be presence of infection, malnutrition, hypoalbuminemia, sepsis, multi-organ failure, open feed container. Yes, all of us in India use open feed container or open system only, right? We don't use a closed system as yet. We don't have an array of products available. And previously, the patient would have been on long-term TPN, then gradually, shifting to EN. So various reasons and risk factors can be there before intolerance of EN is considered. Exclude GI infection. Next, disturbance of nutrient absorption, like milk protein allergy has to be thought about. Exocrine pancreatic insufficiency has to be thought about, as well as lactose intolerance. So some of the medications which can, be a reason for diarrhea in patients with enteral nutrition could be macrolides, which are nothing but the broad spectrum antibiotics, proton pump inhibitors, atropine, metoclopramide, which is used for motility, and medications in suspension with high sorbitol. So you need to have the understanding of all this in order to talk to your doctor. So, as a dietitian, I need to, look at my system also. How are we feeding the patient? Are we feeding through bolus application or continuous? Bolus can aggravate diarrhea, high delivery rate. What is the rate of feeding that I am giving? In a bolus, am I giving 150 ml or 180 ml? Generally, physiological reasons, 120 ml per hour is the well tolerated amount beyond which intolerance can set in. Am I giving a high osmolar product? Is it the osmolarity of the product which is causing the diarrhea? Or is it bacterial contamination of the formula? Where is it prepared? Is it prepared in the bedside? Am I training the nurses to do all the precautions before preparing, or is it prepared in the kitchen where I have a control over my process? Let me revisit my process, right? And is my formula too cold? Is it kept in the fridge and directly served? The ideal temperature is about 20 to 25 degree. So when it is left in the fridge, taken out, make sure it is thawed for some time to room temperature, then it is served. So this is a practical workup algorithm which will help you to understand and devise the process as to how you can modify your care plan. So clinically significant diarrhea, what is it? One time loose stools. Am I going to change the formula? No, don't do that. Be very clear. How many times the patient has passed, loose stools? There is so many definitions, but Aspen gives a definition of if the stool volume is more than 500 ml for 24 hours, or if the patient has 3 stools per day, consecutive days for 2 days, then you start working. Okay. So, clinically significant diarrhea. Is it drug related? Yes. So, stop that drug and continue EN. If it is a no, then ask whether the patient is on antibiotics. So, if it is yes, in a long term, if it is going maybe for a week or so, test the stool for Clostridium difficile toxin and then continue EN. And if it is positive, you can continue EN because they need to taper down on or modify the antibiotics. So if it is no to antibiotics, check on the feed, check on the storage temperature, storage process, preparation process, the temperature at which it is served. Everything needs to be properly analyzed. Then if diarrhea is solved, continue your feed. If it is not solved, look at the way of administration. Is it bolus or continuous? If it is bolus, switch over to continuous. Okay, that will make a difference. If the volume is very high, then you'll have to bring down on the volume. So if it is a no, then change the formula, change the diet formula according to the osmolarity. If it is an S, if it is bolus, switch to continuous and reduce the volume. And then finally, increase gradually to the target volume. It might take maybe a day or two till everything settles. Then you gradually step up and achieve your target. So the next question, are you ready? Typical reason for diarrhea occurring during EN do not include
Yes,
low
polls are stuck.
serum albumin, bacterial contamination, and malabsorption. Which one of the three is not the typical reason for diarrhea, especially in patients on enteral nutrition?
So when the results are here, uh,
Yep.
68% of participants has voted for low serum albumin.
Okay.
22% has voted for bacterial contamination, and 8 has voted for malabsorption.
Oh, okay. The majority wins because it does not include. Okay. It can be a risk factor, but it is not a causative factor. Okay. It's not a typical reason for diarrhea. Okay. So the other two are typical reasons. Bacterial contamination will cause diarrhea, malabsorption will cause diarrhea. Low serum albumin may not cause diarrhea. It could be a risk factor, but it is not the sole reason. So moving on to the next one, nausea and vomiting, which is also common, but it is not as common as diarrhea. It occurs in 15-20% of the population receiving enteral nutrition, and majorly you will find in cancer patients, especially upper gastro GI tract cancers, and when they are in therapy, radiation or chemotherapy, it is a strong trigger. So there are patients who have, very high nausea, which is so predominant, or it's so dominant that it becomes impossible to feed them enterally. In such cases, TPN has to be resorted. And we need to understand the reasons for impaired gastric emptying during EN. It could be pre-existing disease conditions like diabetes, vagotomy, or scleroderma, myopathies, or acute disease related like pain and stress can also impair gastric emptying. Pancreatitis, spinal cord injury, extensive trauma, abdominal surgery, burns, any of this could impair gastric emptying, and medications like opioids and anticholinergics. Okay. And apart from this, it can be aggravated by pain, ascites, immobilization, sedatives, and antibiotics too. And in ventilated patients, a high positive end expiratory pressure, PEEP, might induce vomiting with a risk of aspiration. So, understanding all this before you enter critical care is very, very important. So, how do we, work up for nausea and vomiting, especially in critically ill patients? In case of cancer patients, initiate antiemetic or analgesic therapy, which might support them. If it is really not possible, last resort is TPN, not otherwise. Exclude bowel obstruction. Obstruction could be a cause for impaired gastric emptying. Review on the prescription, because it is so important to understand what type of medication they are on, and which can cause a increase in nausea and vomiting. And if delayed gastric emptying is considered, reduce the delivery rate and try prokinetic drugs like metoclopramides and erythromycin. Constipation is the next one that we're going to deal with, but mind you, it is a very, very, very low number of patients in critical care land up with constipation. Very less common than diarrhea, but it is more prevalent in patients who are on long-term EN. Long-term EN per se, it could be a neurological disorder, it could be a trauma patient, right? So in such cases, you do find patients landing up with constipation. The reasons could be decreased fluid intake, use of high energy dense formula, and lack of dietary fiber. So it is very important that we analyze these scenarios, and mitigatory action should be taken accordingly. The primary goal of constipation is to prevent it, but it is easy to do it, right? Review the prescription and increase the fluid volume, fluid intake, and reduce the density of the formula and switch to a fiber containing formula. Analyze what formula you have given, how much of fiber it contains, or should I need to give a top up fiber to enhance the fiber intake, or switch over to a high fiber formula? That you need to decide. And exclude bowel obstruction. And finally, you can use stool softeners or bowel stimulants. That is the last option. First three things is under our control. You can increase volume, change the formula, add on a top up fiber. These are three things what you can do. Rest of it, doctors will help you, do it. And final thing is aspiration. Aspiration is one of the most critical complication that you find, and it can be fatal too. So, aspiration of oropharyngeal secretions or less commonly gastric or small bowel content is one of the most critical complication of critically ill patient, and it can lead to pneumonia and sepsis. So it becomes very, very risky to have aspiration, which is not really monitored properly, right? So the risk factors being inability to protect the airway, presence of nasoenteric access device by itself, mechanical ventilation, geriatric patients above 70 years, reduced level of consciousness, poor oral hygiene, inadequate nurse to patient ratio. If they are not properly monitored by a nurse, it becomes difficult. Supine positioning. So, it is important that as dietitians, we have to look at all these factors when we go on rounds. Neurological deficit, gastroesophageal reflex, transport out of ICU during the procedures. They go for a CT or an MRI and come back. During transport also there can be some position changes which can be a risk factor for aspiration, and use of bolus intermittent enteral nutrition. That is why we discourage bolus. Okay, in two places we've seen bolus being a reason for a GI complication. So, what is the prevalence of GI complication or enteral tube feed intolerance per se? You see, in this particular study, this was published in 2017. In this particular study, the GRV was the top diagnosis for enteral tube feed intolerance, and it is about 63% compared to nausea vomiting, which is 36%, abdominal pain and distension, which is 29, and diarrhea just 5%. As I told you before, depending on the centers, depending on different studies, these can really vary, depending on their practice. And the combination of signs and symptoms, if you see, combination is about 29%. And you find between the ICU and non-ICU, in ICU, the large gastric residual volume is the highest compared to all other GI symptoms, which are pretty low in ICUs compared to GRV. So, what is the threshold? Many of us really don't get into looking at the GRVs, right? But there is a lot of variation in the practice. And in this particular publication, I found it was 63 studies were correlated, and you find that some say it is less than 150 as a threshold, some say 200, 250, 300, 400, 500, previously given more than previously given en volume, or it is between 250 and 500. What is it? What is right? What is wrong? We don't know, right? So Aspen tells us not to do gastric residual volume. That's what is the guideline, latest guideline. Aspen tells us it is more than 500. So it's a varied practice that is still prevalent, and in India, it is institutional practices, right? And how do we get over this? Prefer a semi-recumbent position, which is about 30 to 45-degree head end elevation, which is very important as dietitians when you walk into your ICU. This is one of the components that you have to see. And if in case aspiration is high, prefer nasojejunal instead of nasogastric. But we, in our institution, we are strong believers of NG. And by and large, we are very, very successful with NG tube feeding. If in case there is an issue of aspiration for such patients, you can think of nasojejunal. In case of clinical changes, measure GRV and adjust the delivery rate. If it is very high, they normally give a break. They might start on prokinetics, then they will decrease the delivery rate and start slow. So to read more about, GI intolerance, it is few things that we have looked at, and I wanted to give you a little more information. So I thought, I will Google out, read more, and I found a very interesting paper which was published in Nutrition and Clinical Practice in April 2020, latest paper, where this paper talks about dispelling myths and unfound practices about enteral nutrition. So it really, I felt it was the right paper that I have to discuss with you. And it discussed about 20 plus myths and unfound practices. I'm just picking a few which related to our topic. So the first one is elemental and semi elemental formula are the preferred formula choice of administration through jejunal tubes. Traditionally, that is what we used to believe, right? Traditionally, we used to give only semi elemental formula through jejunal tube because of the tube size was small and concerns about digestion, absorptive capacity of the GI tract. And what we found, there is no concrete recommendation based on limited data and research available. So, individual, you need to consider an elemental or semi elemental formula only if the individual has symptomatic malabsorption disorders. So, if the gut is fine, there is no major trauma or major disease to your intestine, jejunal feeding, normal polymeric feed is suitable. And if you find the absorption is inadequate, the patient has, some sort of GI disturbance, then think of probable and elemental or semi-elemental formula. And formula choice is based on patient's GI condition and tolerance, and not about the tube, placement of tube. It is very, very important that we understand that. The next one, is it appropriate to add modular components directly to enteral formula? There are people who do advocate, adding modular formulas. It could be a carbohydrate or a protein or a fat, and feed the patient. But do not mix modular formulas directly to the enteral formula that you're feeding, because that should be administered as a medication through flush. Okay, you take out a scoop of the modular formula, mix it in water, then push it or flush it through the RT. That is a better method than directly mixing it with the enteral formula, because that is not appropriate. It has to be administered as a medication, not as, it should not be mixed with the enteral formula. The next thing which really was of interest to me was EN associated diarrhea is almost always caused by formula. This is a myth. That is how we are spoken, right? Many of the doctors immediately tell us, can you change the formula? What are you giving? I think the patient is having diarrhea. Can you do that? Not in my ICU, but previously, maybe a decade or 1.5 decades back, when we used to use blenderized formulas, we used to have this problem. If they see the dietitian, immediately they will talk about blendoria. Okay, so it is so important for us to understand what is diarrhea. I did explain this to you before. So diarrhea, you have to be very clear. It has to be more than 3 stools for at least 2 consecutive or more number of days. So it could be attributed to so many factors that we discussed. It could be medication, it could be a GI disease, it could be post-surgery, it could be infection. List out everything. Look out what is happening to your patient. Then think about changing the formula. That should be the last resort. So the recommendation from Aspen to manage diarrhea is rule out the above causes, like whatever I spelled out now. Once C. difficile is ruled out and is being treated, consider an anti-diarrhea agent. If the above are completed and symptoms continue, then consider changing the formula. EN related diarrhea is multifactorial and is not often related to enteral formula. Be very, very clear about it. You need to really understand it and speak. And one more, EN should be held in adult critically ill patients if GRV is more than 200. Long held belief, right? That aspiration risk increases with GRV of more than 100 ml led to this myth. Yes, little more than usual, they will stop the feed. That's how it happens. Many institutions they practice. Okay, so be very clear, make them understand. Aspen tells us not to see GRV, and even if you see, Aspen tells us 500. So we are not very, very clear. And some of the latest studies have checked up no checking of GRV with checking about more than 250 threshold to give a better caloric delivery. And the summary, what they recommended was GRV should not be routinely measured. However, when GRV is measured, use a high volume more than 200 ml to trigger the clinician to consider holding enteral feeding. It is a trigger given to the clinician. He has to decide, looking at all the different parameters, whether to hold it or continue. It can differ. It may not be the same for every patient. It has to be the clinical judgment of the clinician for the particular case. So, finally, looking at the complication. This may not be part of our GI intolerance, but I thought I should put it in front because, many of us handle patients who are long-term in on EN, and this is a frequent question what we get. Use of cola, soda, meat tenderizers, pineapple, cranberry juice to prevent clogging or to unclog the feeding tube. Very common. Background is it is believed that alternate liquids could prevent and treat feeding tube clogs. Please understand the best thing is to flush it with water. 30 ml of water every fourth hourly during continuous feeding and before and after intermittent feeding. It's about 30 ml, just flush it in. Okay, this is what you should advise your nurse on a regular basis. And for prevention and treatment of tube feeding clog, using water is the best because I did have a patient very recently. I had an encounter with her grandson, who's also a doctor, and he uses soda to flush her grandmom's peg tube because he says water doesn't help. Simple. Because I don't know how frequently they flush it. So they flush it with soda to release the clog, then feed the patient. If it has to be, repeatedly emphasized that they have to flush the tube every fourth hourly so that tube clogging is not a problem, and it has to be only with water. And cranberry juice or carbonated beverages may worsen the condition because of the acidic pH of these fluids. So be very, very firm and clear that they cannot use all of this. So we did see a elaborate view about the GI intolerances. Then comes, how do I choose my formula? Correct? There's always a confusion, especially little ones who go to critical care or budding critical care dietitians will always have a problem. So to make it easy, this algorithm will help you. First thing you have to understand is GI function is an important patient related factor in choosing enteral formula, right? So GI function, if it is normal, straight, no doubts, go to a polymeric feed. And if it is normal and you want to choose a disease specific formula, you have an array of it available. And that is also polymeric formula only. You can be very, very clear in choosing according to the prescription. It could be according to the salt restriction or volume restriction, and whether he's diabetic, depending on whatever be the comorbid factors and the prescription given to you, choose the product. And if in case the GI function is impaired, then depending on the percentage of impairment, depending on how well he is able to absorb, you can think of choosing products because Mechanically ventilated patients, as we discussed before, have always got a compromised GI function. So then you deviate to whether you want to choose a disease specific formula or a semi elemental formula if in case he has a a shorter gut absorption is a problem, GI tract has a issue, he might have a, GI disorder, IBD. So then you can think of semi-elemental diet. Semi-elemental formulas are nothing but they have hydrolyzed macronutrients which aid in absorption, especially your protein, and available in different energy and protein densities. And where do we recommend this? Wherever you have impaired gastrointestinal tract functioning, where there is malabsorption, post gastrointestinal tract surgeries with reduced absorptive areas, or prolonged bowel rest. After a very long time, after a very long starvation, you're starting on somebody who's severely malnourished. I would encourage practice purpose. You can start on a semi elemental formula till the patient gets better, then switch over to a polymeric formula. If there is chyle leak, obviously semi elemental formula comes in really handy because it is rich in MCT. Pancreatic dysfunction, severe malnutrition, as I discussed, and gut edema and malabsorption. There are cases who have gut edema. In such cases, also elemental or semi elemental formulas come in real handy and really helps. Then other factors, what you should look at before you choose an enteral formula are patient related factors like medical situation, medical history, surgery, how good is this gastrointestinal tract, and how is the nutritional status of the patient. Is he severely malnourished? Patient has allergy. Yes, you need to note the allergies also. Recently, we had a patient who had fructose allergy. So, you have to be careful whether you look at the formula, whether the formula has fructose or not. And management of complications, disease specific formulas, biochemical abnormalities, malabsorption, diarrhea, all those have to be noted. Look at your prescription, whether it is a nasogastric or nasojejunal feeding, but depending on the functionality of the tract, you can choose your product. And nutritional requirement, according to that, your formula will differ. And implementation of feeds, whether it is continuous or bolus or intermittent, depending on the protocols what you maintain in your system. But what is generally advocated is continuous feeding, because I have given you so many reasons why continuous feeding is much better compared to bolus. And availability of feeding pumps, yes, that's administrative thing. you know you need to talk to your institution. If it has to be a continuous feeding, pump has to be there. Okay. And other logistic with regard to budgets, tenders, available staff, yeah, staffing has to be adequate. Okay. So what does guidelines say about your choice? How do we choose? So in adult critically ill patient, what are the indications, if any, for enteral formulations containing soluble fiber or small peptides? And they suggest consider use of small peptide formulations in patients with persistent diarrhea or with suspected malabsorption or lack of response to fiber. If in case a patient doesn't respond to soluble fiber, think of shifting it to a semi-elemental formula. So now the polling question. I'll get a break now.
Okay. So we have started the
Polling.
polling.
Okay.
Yes.
Monitoring is very, very important. All of you know that. So monitoring of enteral nutrition should include select one of the following: nutritional status, laboratory test, tube and EN related complications, or all of the above.
So we'll give 20 seconds for the participants to answer.
Yep.
I think, ma'am, going towards the end of this session,
Yes.
these questions are improving the status of the questions.
Very good. It's all of the above, girls. Okay, let's move on because it's
Yes,
getting late.
yes.
Okay.
Almost 90%
Oh,
at the
wow, very
yes.
good. So, monitoring, so nutritional monitoring is important. You have to make sure what you prescribe is delivered and fluid balance, weighing the patient. It is a difficult task. If in case you're able to do that, you try to monitor and laboratory per se, sodium, potassium, glucose. And urea, creatinine, depending on the criticality, it is daily in the initial phase, then it becomes weekly. And hand grip strength, weekly they advise you to monitor, may not be in a comatized patient, but in patients who are on long term tube feed, you will really understand the outcome very well. And tube related complications like nausea, vomiting, diarrhea, these have to be monitored by the dietitian on a regular basis, because this will help you to relate to the delivery of nutrients, right? That is what you prescribe. Has it been delivered? Has to be monitored. And moving on, there's a lot of importance given to gastrointestinal manifestations in COVID patients, because most of the COVID patients have some or the other GI issue. It could be diarrhea, nausea. This study particularly speaks about general population, general COVID patients, non-critical, but they also have a percentage of GI issue. So, don't you think it is a challenging thing for COVID critically ill patients, especially in early and late acute phases? Okay, intubated, deeply sedated, and in prone positions. And nutrition support practices should be adjusted according to the GI tolerance, and it has to be addressed very regularly. And this is one of the paper which is published, yet to be published or published in Nutrition in Critical Practice, July 2020. And it talks about the recommendations, and it is slightly different from the usual recommendations, because in COVID perspective, it has to be instant, right? You cannot prolong. So if the patient has nausea, add prokinetics to improve the motility. And if there is delayed gastric emptying, do not concentrate the enteral feed, dilute it a bit, consider postpyloric, you know. And next is abdominal distension, reduce feeding rate, and shift to a energy dense formula. Lower volume, higher calorie and protein, because that is the need of the hour for COVIDs. And diarrhea, no ifs and buts, directly shift to semi-elemented pre-digested formula to reduce diarrhea and for better absorption. This was something very new that I learned. I thought I should share, because you don't go through the whole process of looking at various things, because other things may not be altered at all, but feed can be altered in COVID scenario. So, and COVID and proning is very common. We did discuss a bit last week, and about hyperglycemia in COVID. Today, COVID and GI intolerance, especially in patients who are prone. How many of you feed a prone patient? That itself is a question, whether it is safe, whether it is feasible. It is feasible. Okay, there are a lot of studies to say that this paper was published in 2014, and they did find that there is no major difference between the supine position and prone position with regard to volume delivered and the gastric residual volume. And safety perspective, you see there is no difference between vomiting, regurgitation. Both supine and prone are same. One more study, this particular study, they concluded that in critically ill patients with severe hypoxia receiving mechanical ventilation, most of them were ARDS patients with pneumonia. It was feasible to feed the patient in prone position, safe, and not related to increased risk of GI complications. Next, this is our publication which we did this year in January, if I'm right, 2020. And what we did was a little higher number. 47 patients were included who were prone and ARDS patients. So their Apache, you find it is so high, as high as 26. plus or minus 9. Okay. And route of feeding, nasogastric feeding was predominantly, as I told you before, we are people who, like to feed the gut, gastric feeding. Nasogastric is 74% and 62% discharged home, and average proning hours is about 47 hours, which is also quite high, right? So how did we achieve our targets? You do find a bit of decrease in the protein. There was no difference in the calories provided between proning and supination period, but there is a bit decrease in the protein, which was significant but not a major thing, 75% and 80%. So that is how it is feasible to do it. But when you look at the interruptions, you find that GI bleed was zero, diarrhea was zero, more than 250 GRV was about 32, which is more than double the percentage in supination period. This is 12.3%, whereas in supination is 24.1%. So don't worry, you can feed. There was no nausea, no vomiting during pronation. And why am I talking about it? Is because during this COVID pandemic, to improve oxygenation, patients who are critically ill are prone. You can feed the patient in par with supination position. Okay. So in critically ill patients receiving invasive mechanical ventilation in the prone position, EN is feasible and well tolerated with continuous nasogastric or orogastric feeding. Nutritional delivery in prone position is comparable with supine position. And the take home message is compromised GI function is more common in critical illness. GI intolerance is multifactorial, but often erroneously associated with enteral nutrition. And EN related myths should be refuted with facts and evidence based scientific findings to make this therapy safe and effective. And nutritional delivery in prone position is feasible, safe, and is comparable with supine position. Thank you.
Thank you so much, ma'am, for that wonderful presentation. It was very well explained. So we have a few of the questions already with us.
Okay. Okay.
Uh, so first question goes from Miss Tong. What is your view about using semi-peptide feeds for the patients with high GRV, despite of using prokinetics? So
Uh,
have you come across any particular researches about this in any?
no, if in case the GRV comes down with prokinetics, you don't have to shift the formula. A normal polymeric lactose free product is perfectly okay. If the tolerance does not improve, think of using a peptide. Stepwise, you should go. Don't jump into conclusion first itself.
So, ma'am, there is another question from Miss Sangeeta. If a patient has thickened sigmoid and he is constipated, can we provide fiber supplements for these patients?
Yes, you can. It can be a combination of soluble and an insoluble fiber, which can be, if he's on tube feed, it can be flushed through the tube. It should not be added, as I told you, anything, anything modular, anything separate. You cannot add it to the formula. You can very well flush it. It'll help.
Okay. So, ma'am, a question from Miss Priya. In Crohn's disease, what kind of supplemental formulas can be given?
Crohn's disease, depending on the patient's condition, if they are able to tolerate a polymeric formula, it is fine. But in my experience, I normally use semi-elemental formulas, which are very well accepted and tolerated. Because generally, Crohn's patients, they come after a major bout, right? They come when they are sick. They don't come when they are
Mm,
normal. So when they are sick, semi-elemental works very well. And maybe after they are, fine and they get back home, if they tolerate polymeric lactose-free product, it is fine. You can upgrade it to that.
okay. So, ma'am, another question from Miss Ritu. Do you give semi-elemental formula only in jejunal feeding, or it can be, in other case also?
When the patient is intolerant, in nasogastric also we give semi-elemental. Very, very clear, underline it. If they are intolerant to a polymeric formula, then you think of semi-elemental. In jejunal feeding also, we do give normal polymeric formulas. If the patient's gut is pretty normal, he really tolerates it very well. If they have a GI compromise, then sometimes it is, they have difficulty. In that case, semi elemental comes in very, very handy. They tolerate it well.
So
It
I
is
guess.
very much case based.
Hmm.
Nothing can be generalized. It is a case based approach that you have to take. You need to analyze all the factors what is discussed and come to a conclusion. Be very, very scientific in what you're doing. Go stepwise, then you will not miss anything.
Yes. So there's another question from Ms. Tong. Can patient lie flat for 10 to 15 minutes to perform muscle ultrasound or body impedance analysis during continuous feeding?
Uh,
If
can
continuous feeding is given,
hmm.
so during continuous feeding, can patient lie for 10 to 15 minutes for any kind of procedures or anything?
Yeah, 10 minutes or so. This was one of the question in that myth.
Hmm.
The paper that I explained, there, this question was there. Can they be, is that that they should not be put in supine at all when they are on tube feed? No, it's not that way.
Hmm.
If it is 5 to 10 minutes, you're doing some procedure, you're turning the patient, if he's a stable person, it is perfectly okay. Otherwise, if the number of minutes or hours increases, then it becomes a major issue. So, if you are able to do it with a head end elevated, then it is fine. You can do it. If that is not possible, think of putting him in a supine position.
Okay. So, ma'am, okay. So, ma'am, question by Miss Khatija. What is the maximum rate given through jejunal feed?
Jejunal feed, you can give, if it is gastric, it is up to 120. Jejunal can be 75 to 80 ml per hour, should be well tolerated, not beyond that. So, depending on the volume suggested, choose the product accordingly. You can tweak the, concentration of the formula to achieve the
Okay.
goal.
So, after how much time, we shall check the GRV in case of continuous feeding? A question.
Continuous feeding, every sixth thali, people, do the check. There are institutions where they check every fourth thali. See, it is very much institutional practice. There is no specific norm that has been advised globally. So, in general, every sixth thali they advise.
So, ma'am, in case of corona patients, corona infected patients, COVID patients, are there any restrictions for any specific formulas, or it can be given, any
No,
formulas?
normal polymeric formula is very well tolerated by COVID patients, and their requirement of protein is very high. Calorie per se in the initial phase is pretty low. It's about 15 to 20 calories per kg body weight, and protein as high as 1.2, which goes to 1.5 plus in the second week. So, accordingly, you need to choose the formula. Otherwise, you may not be able to meet the targets, right?
Hmm.
And depending on the tolerance of the patient, you can think of, shifting it to a, semi-elemental if he is intolerant. Very clear.
Okay. Uh, so, ma'am, there is a suggestion, so request from the one of the participant. They are saying that how can they, help themselves? So, do you have any recommendations for any specific book which has such kind of detailed information so that they can refer to for their own,
Mm,
practice? So, any
We do
particular book for a reference to,
for
learn?
COVID or for
No, no,
COVID.
in general for nutrition. for
Uh-huh.
dietetics for any dietitian. So any
Uh-huh.
particular book which is much it has much more information in depth. So what would you recommend? Any particular book?
Practice oriented tips. We had made a pocketbook which we used to circulate. If somebody is interested, they can get it from our department also, because getting all the latest into practice, you need to keep upgrading yourself. You cannot stick on to any particular book. You need to look out for articles which are coming, researches which are coming. That is how you improve your practice. So don't become too bookish, because books become outdated very soon.
So do maltodextrin in supplements impact the glycemic control?
Maltodextrin in supplements, yes, some of the products do have maltodextrin. It is in our practice, we didn't find any major change. It is good. The glycemic control seems to be quite good, so you can use it.
Okay. So thank you so much, ma'am, for your wonderful presentation and also a very meaningful discussion. So my sincere thanks to you for enlightening us, in this for with this information. And I thank all the participants and you on behalf of Mr. Abdul Hanan, who is our cluster business head for the SAR region, and entire Nestle Health Science team. So thank you so much, everyone. We appreciate you being here and sparing your valuable time with us. So stay safe, stay healthy. Goodbye.
Bye bye.
Bye.
See ya. Bye.